Tomihisa today will talk us about predictors of switch to mania in depression in bipolar disorder. Please.
I'd like to talk about our new research about switch. The singular phenomenon of switching from depression to mania and vice versa distinguishes bipolar disorder from all other psychiatric disorders. The mechanisms and the neurobiology of the switch process is still poorly understood. Manic switches represent a crucial problem for the treatment of bipolar disorder. Previous studies reported risk factors of switch, risk factors of antidepressants, risk factors of switch, for example, sleep deprivation, exogenous corticosteroids, dopaminergic agonists, TCS, abnormalities in catecholamine levels, correlation of neurotropic and neuroplastic factors, HPA axis hyperactivity, circadian rhythms, and so on. Then risk factors of antidepressants induced manic switch were also reported. For example, lower number of previous manic episodes, less presence of delusions, depressive polarity of onset episode, more frequent mood stabilizing treatment, and an earlier age at onset, and illness course characterized by lower rate of response to antidepressants, higher rate of switches into mania or hypomania. However, the results are still inconclusive. Previous studies investigated a following phenotype of switch in bipolar disorder: switcher or non-switcher. Switcher is patient with history of the switch, and non-switcher is patient without a history of switch. These previous studies provided evidences about the mechanisms of switch. Patients with bipolar disorder suffer repeated episodes of bipolar depression during the course of the illness. In clinical settings, clinicians are continuously concerned about risk of switch in treating depressive patients with bipolar disorder. Therefore, clinicians would like to know whether this depression patient with bipolar disorder is at high risk of switch. This is our clinical question. In order to answer this question, we set our aim of this study as follows: to investigate predictors of switch to manic mixed episode in depressive patients with bipolar disorder. Next, I'd like to talk about methods. We used the database of the STEP-BD. STEP-BD stands for Systematic Treatment Enhancement Program for Bipolar Disorder. This study is a multi-center longitudinal NIMH project, naturalistic design. Basic clinical research needed is to test treatment with demonstrable efficacy in double-blind trials in open clinical practice. Patients are diagnosed as DSM-4 criteria for bipolar 1, bipolar 2, psychosthenia, bipolar or schizoaffective manic, or bipolar Patients were assessed for demographic data, past history, and baseline data. Then patients were repeatedly assessed for current clinical data using clinical monitoring form. This schema shows the definition of switch using the CMF dataset. Switch was defined as a depressive episode followed by manic or manic mixed episode within 12 weeks. And switchers was defined as a patient with at least one depressive episode with switch during total follow-up period. We use generalized linear mixed models for analysis, for statistical analysis. GLMM allows the data from all depressive episodes of each patient to be used in the analysis. Dependent variables was depressive episodes with switch or without switch. Patient ID was used as random effect. Statistical significance set at 0.05. Then SDSS software was used. In order to select covariates to be adjusted, we made 5 models. In model 1, this shows not adjusted models. And model 2, demographic data and socio-economic status and stability duration related variables were selected as covariates and adjusted. In model 3, covariates in model 2 and variables selected from the significant variables of past history were adjusted. In similar way, in model 4 and 5, also covariates were selected. I would like to explain these models using schemas. This schema shows associations of variables and model 1. These arrows means associations or effects. Past history has some effects on baseline data and current clinical data. Baseline data has some effects on current clinical data at depressive episodes. This schema shows model 2, demographic, socio-economic status, and durations data were adjusted. Variables of past history were associated with switch via blue arrows. This schema shows model 3. In addition to demographic, socio-economic status, and duration variables, variables selected from the significant variables of past history in model 2 were adjusted. Variables of baseline clinical data were associated with switch via green arrows. This schema shows model 4. In addition to covariate in model 3, variables selected from the significant variables of baseline clinical data in model 3 were adjusted. Variables of current clinical data were associated with switch via an orange arrow. This schema shows model 5, namely full adjusted model. In addition to covariate in model 4, variables selected from the significant variables of current clinical data in model 4 were adjusted. Each variable of current clinical data was associated with switch via an orange arrow. 5,000 episodes. This is about 1,000 patients in each model. A combination of variables minimizing the collected archaic information criterion was selected by stepwise manner and included into a next step model as covariates. AIC is a good tool to choose a better forecasting model. We also conducted multiple linearity diagnostics to scan a correlation and to check the VIF, variance inflation factors, and tolerance. I will show you the results. This table shows sample characteristics separated by non-switcher and switcher. The total number of analyzed depressive episodes was 8,950 episodes. Of these episodes, 512 depressive episodes were with switch. The number of depressive episodes during follow-up period was higher in switcher. And follow-up duration from step PD consent was longer in switcher. Then age at onset of Manic episode was younger in switcher. This slide shows the selected covariates in each model. No multiple linearity was found between all of the predictor variables in each model. For example, model 2 includes demographic variables and socioeconomic variables and durations. Then model 3 includes covariates in model 2 and newly selected variables. Then model 4 includes covariates in model 3 and these variables. And model 5 includes covariates in model 4 and newly selected variables. These demographic and past history variables show significant association with switch in model 2. Red colored variables were included into model 3 as covariates. For example, demographic data. Age was associated with switch. Younger age associated with switch, more high risk of switch. Duration from step PD consent to depressive episode. Show the duration associated with switch. Number of episodes. Number of Manic episode in lifetime. Number of depressive episode lifetime. Number of phases in lifetime. History of last year rapid cycle. And psychiatric history before baseline. GAD, generalized anxiety disorder, was associated with switch. Suicide attempt associated with switch. Night terrors and amphetamine use, opiate use. These variables were associated with switch. Then past treatment history before baseline. switchers has no, sorry. Bupropion was used, less used in switcher, associated with switch, no use. On the other hand, the quetiapine was more used in switcher. Psychotherapy is more or less used in switch. And the other variables also associated with switch. Then these baseline variables show significant association with switch in model 3. For example, ideas of reference associated with switch, or high manic symptoms associated with switch. And then these variables show significant association with switch. This is current clinical data at depressive episodes. For example, mood elevation or irritability, psychomotor agitation. More severe symptoms were associated with switch. Then associated features are also associated with switch. Panic attacks or hallucinations associated with switch. And current treatment, venlafaxine use was associated with switch. These variables show the significant association with switch in full adjusted model 5. Panic attacks and hallucination. Next discussion. Our results suggest these possible risk factors of switch in depressive patients with bipolar disorder. However, these variables may, the possible predictor risk factor of switch. Younger age, higher number of past episodes, more frequent past history of GAD, suicidal attempt, substance abuse, ideas of reference, night terrors, and more frequent history of affective switch by antidepressants, or less provided psychotherapy. However, these variables may be sure risk factors of switch. So I think that these variables should be checked, the association with other variables. Because, for example, less frequent history of antidepressants treatment were associated with switch. I think this derived from the fact that clinicians would avoid to prescribe antidepressants to patients with high risk of switch. hallucination symptoms are promising predictors for switch in depressive patients with bipolar disorder. Venlafaxine treatment and subthreshold manic symptoms in depressive episodes may be possible predictors for switch in depressive patients with bipolar disorder. Younger age and several past history items may be possible risk factors of switch in depressive patients with bipolar disorder.
Thank you, thank you, thank you.